I welcome everyone. Good afternoon. This is an exciting day here at Children's National because it's the first day we are able to vaccinate our 12 to 15-year-olds against the coronavirus. So we're now over 400 days into the pandemic. And as we all know, these kids have been rock stars. They've paused their whole life to protect themselves and the more vulnerable adults in their lives. And today, a big part of the pediatric population gets to start getting vaccinated. So it's a huge win. And I first want to say huge kudos and gratitude to all the literally hundreds, if not thousands of people that have worked over the last year at this institution and around the city to make this to make this possible today. And our goal for this talk today is to really give you information to keep the momentum and to help get as many kids vaccinated as we can. Today's agenda is on the board. We have an excellent group of speakers, all experts in the field, and we hope we can touch on many questions that we've been receiving from medical staff. So we want to talk about the vaccine and the hesitancy that many people experience, the thoughtfulness they're putting into the decision about getting vaccinated. Then we have some educational resources that we'll offer you. And then we'll give you updates on what Children's National is doing both in the outpatient centers and in the inpatient centers. And then we'll end with an update on the Pfizer trial for the next round of children, 6 months to 12 years old. All right, so again, those are some of our objectives, and I will pass it on to our first speaker, Dr. Alexandra Yantz, to talk about vaccine hesitancy.
All right, hello everyone. I'm Alexandra Yantz, one of the infectious disease providers at Children's National, and I will be speaking a little bit today about COVID-19 vaccine hesitancy. I will preface this with saying vaccine hesitancy is a much larger issue, one that we're not going to solve in 15 minutes over a webinar, but the goal of this talk is to both update a little bit on new information for the Pfizer vaccine in particular in our 12 to 15-year-old populations, which was just approved over the last week or two, and some of the safety information that may be helpful for you all as primary care providers when discussing with your patients and their families, and also to address some of the key issues more or less unique to COVID-19 vaccine hesitancy, and some strategies and resources for how to begin to address those issues. I'm just trying to advance my slides. There we go. As mentioned, catching up, where are we on pediatric COVID-19 vaccines? As I mentioned, just this past week, Pfizer has been given emergency use authorization status for their vaccine for ages 12 and up. And this is something that was discussed and approved also by the ACIP, or the CDC sort of vaccination guidelines and recommendations committee. So this is very exciting news. There are ongoing studies in the pediatric population. So currently there is a phase 1 dose finding study for 6 month to 11-year-old patients. And once that's completed, unfortunately the bar is in the wrong place, but we at Children's National, led by Dr. Bud Wiederman, who you will be hearing from later in today's town hall, will be participating in the phase 2 and phase 3 trials in this same population that are anticipated to start enrolling by the end of this month. So very exciting news. We will hopefully be able to broaden this vaccine coverage to our other patients. And then, as you are probably aware, there are a couple other vaccines that have been approved under EUA in the United States through the FDA. So Moderna has their mRNA vaccine that's currently approved for ages 18 and up, but being studied in 12 to 17-year-olds. And we anticipate those results to be coming in the next month or so. And then Johnson & Johnson with their single-dose adenoviral vector vaccine is also approved for 18 and up with a new warning for younger women, given the clotting concerns that have recently been reported. And there are plans to do pediatric studies, but those have not yet been initiated. So just a brief recap again with some safety data. This is taken from the ACIP presentation that was on Wednesday of this past week, so May 12th. There were 2,200 children ages 12 to 15 that were enrolled in this study, received 2 doses of the Pfizer vaccine, and they followed them, same time frame as they had in the adult studies for any side effects and signs of reactogenicity. And generally, the vaccine was similarly tolerated as it was in the 16 to 25-year-old population. So these two slides show first dose and second dose findings of reactogenicity. And there are two columns in each category. One is for 12 to 15-year-olds, and one is for the older comparator group of 16 to 25-year-olds. You can see for most things, fatigue, headache, chills, it was pretty comparable between the younger and older age groups. I didn't show this slide, but injection site pain was the most common in all comers. Almost everyone had some complaint of injection site pain, which is expected in most vaccines. And then the biggest difference, however, and still a very small difference, was slightly more common for children in the 12 to 15-year-old group to have fever after vaccination. So within the first 7 days after dose one, it was 10% of 12 to 15-year-olds versus 7% of older group. And then slightly higher rates, almost doubled, 19.6% in the 12 to 15-year-olds had fever within 7 days of vaccination, compared to 17% of older. So that's still not a lot, still the minority of patients, but something to keep in mind when you're talking to families as information they might want to know. And then looking at adverse events beyond what we call reactogenicity, or the things that we sort of anticipate with the vaccine within the first week. Out to date, so as of March 13th, which I think was the data lock, they had data on all of the children for at least 4 weeks after the second dose, and some for a much longer period of time. 6% of all subjects, all 12 to 15-year-olds who received the vaccine, reported any adverse event. And again, most of those were related to vaccine reactogenicity type of things. So again, injection site reaction, nausea, diarrhea, headache, and only one patient out of that group withdrew due to the adverse events. So they were generally mild or moderate. None of them were very severe. You'll see this is actually a lower rate. So the 12 to 15-year-olds are on the top slide with that 6% in the vaccine group and 5.9% of subjects with the adverse event in the lighter blue bar for placebo. The lower group, so 16 to 25-year-olds, and they actually had a higher incidence of adverse events. So this is actually ultimately reassuring that this vaccine is safe in younger children, or 12 to 15-year-olds. And there were no deaths in either population in these studies, which is also very, very reassuring. Briefly touching on, again, just because parents may ask and want to know, this vaccine was demonstrated to be 100% efficacious in looking at cases of symptomatic COVID. So there were 0 cases in the vaccine group and 16 cases in the placebo group. Obviously, this is low numbers. There's a very wide confidence interval, but in keeping with what we've seen in the larger adult studies. So this is consistent, as were their levels of antibodies that were detected. So they actually had children in this group that were vaccinated had higher total antibody titers than the adults did. So indicating a very robust immune response that is safe and efficacious. So now, knowing all that, also wanted to put in a brief plug. If you are interested in hearing more about COVID-19 vaccination across the board in pediatrics, so including plans for regulation and decision and licensing timeline for the younger age groups, as well as in other vaccines, so Moderna, J&J, et cetera. The FDA is holding their next Vaccine and Related Biological Products Advisory Committee, or VRBPAC, as it is called, on June 10th. That will be PED specific and is available to be viewed on a webcast with a link at the fda.gov. So I would encourage you all, if you're interested, to tune in for parts of that, because there's always very interesting discussion and good materials. So pivoting to the question at hand. So recently, a CNN vaccine poll conducted at the end of April showed that about a quarter of adults were not interested in getting the COVID vaccine now or ever in the future. That was specifically addressing individuals about their own vaccination plans. So there have been subsequent polls done, one by the Kaiser Family Foundation, which was a much more extensive survey, just last week regarding parental attitudes about COVID-19 vaccination for their children. And what this survey showed was that essentially parents who had no plans for vaccination themselves also had no plans to vaccinate their children, which somewhat stands to reason, for a reason, depending on why they're hesitant for their own vaccination. And this seemed to be a little bit age dependent as well. So even for those who fully plan on vaccinating themselves or are open to vaccinating themselves. So in this slide on the left, you can see that in particular for parents of children under the age of 5, there is a higher percentage of those who were sort of in the middle about their thoughts on vaccine. So we're hoping to wait a while to make a decision to get their own vaccine, but we're not closed off to it. A significantly higher percentage of those individuals would also want to wait on vaccinating their children, as opposed to those that are slightly older. And then this is echoed again on the right slide, in which parents who, again, are in that middle group are the ones that are waiting for more information or more safety data, or just waiting in general, have a similar watch and wait and see approach for their children, as opposed to either side, where parents that are going to get it and we're going to get it before it was even announced and we're very excited are going to give it to their children, and parents on the other side who are not going to get it no matter what you say is really going to change their mind about getting it for themselves or their children. So this middle group is probably where we as pediatricians have the most potential for impact, to provide information, address the myths, and hopefully convince them to get their children vaccinated, or at least have a good discussion about why it's necessary, and why it's scientifically and recommended. So the main drivers of hesitancy, and I will confess that most of this framework came from a great paper by Rutan et al. Published in Mayo Clinic Proceedings just this past month, looked at the different sort of buckets or reasons why people are not interested in vaccinating or hesitant about vaccinating with COVID-19 vaccines. And so there's really 3 main areas. So there's vaccine-specific attributes, really safety being the biggest one, and I'll touch on that a little bit more in a minute. There are also political factors. So there's been a lot of governmental mistrust, as you're aware, with masking, and so much of this pandemic, there's a lot of political heat based on whatever your political leanings are, and the media and their opinions on things. So that has flavored people's willingness to get vaccinated in a lot of different ways, as well as more historical government mistrust due to unfortunate research ethics violations in the past, such as the Tuskegee experiment. And then there's a third area of vaccine-related attitudes and beliefs, which is a little bit more of a mixed bag, kind of gets more at personal concerns. So often there are some cultural barriers or beliefs about vaccines that are less pro-vaccination, if you will. Populations that are younger and lower SES may or may not be as interested in getting vaccinated, sometimes due to lack of perceived need, seeing that there's not as high a consequence, I suppose, if they personally get ill. And then there are some individuals that have a preference for natural immunity, and believe that this is a better way of doing things. You can address these issues in various ways, but the most data we have really supports addressing vaccine-specific attributes at this time. So effectiveness of the vaccine, duration of protection, and safety. And just to echo a little bit more how the safety concerns are really one of the biggest things that we worry about and see in vaccine hesitancy. The U.S. Census Bureau has been doing pulse surveys of different areas about certain COVID questions, and one of those is interest or disinterest in getting the vaccine. And so in early March, they did one for the DC area, and in that group of all individuals who were not interested in getting COVID vaccination at that time, more than 50% listed safety concerns or concerns about possible side effects as their main reason for not wanting to be vaccinated. And this was even higher in certain key demographics. So particular, the groups that have been most disproportionately affected by COVID, Black and Latino populations had even higher rates of responding with safety concerns. The second most popular answer was mistrust in government, which represented about 22% of the respondents. And then I think overlying all of this is this cloud of misinformation that's out there. So with social media, news media, everything else on the internet, family concerns, chatter, there are a lot of rumors and myths and just questions going around. And that is something that obviously affects all of these other areas. And so I will chat in a few slides just about some ways to address misinformation in a way that's respectful and doesn't basically have a paradoxical effect and get more pushback from the patients that you're talking to about these issues. So from that same Mayo paper that I mentioned, this is just a nice figure they had with the overall framework for how to address COVID-19 vaccine hesitancy and what the most important factors are. And really, one of the things that has been demonstrated, not just in this realm, but also in previous studies of vaccine hesitancy, since this is an ongoing problem in this country and across the world, is that strong clinician recommendations are one of the most powerful factors. So time and time again, respondents have said that if their physician, particularly their personal or family physician, someone that they have an established relationship and trust, said, you will get this vaccine, or I recommend this vaccine for you, that they were more willing to get the vaccine. So that personal connection and a strong declarative recommendation are sort of the most powerful tools in your tool belt as pediatricians. And one example of that is using a default, say, rather than asking if they're interested in the vaccine today, say, we have the vaccine today and your child should receive it, or I've scheduled you for your COVID vaccine today. So leaving no room for waffling in terms of how you recommend the vaccine. Sort of the other factors we'll talk about a little bit more, but a lot of providing information, providing factual details, as well as appealing to the more positive aspects of vaccination and why this is important rather than fear-based tactics. So addressing hesitancy, as I mentioned, strong provider recommendation is the #1 tool in your tool belt. Having a positive approach, as I mentioned, is another key way to go about this. So focusing on the benefits. So saying, if you get COVID-19 vaccine, it will protect you and your family and your loved ones in your community from getting this virus. Rather than saying, if you don't get this vaccine, everyone around you will get sick and die. Studies have shown that positive approach and also appealing to altruism. So saying this will help others in your community who may not be able to get vaccinated is effective. So take a happier spin on things. Addressing the misinformation can be a tricky task. But there are certain ways that are better than others to go about it. So one of those being to validate concerns and the values of the family. So understand why they are concerned about a particular piece of misinformation, where their concerns come from, and then address those with facts that either disprove or their concerns, but not being wholesale dismissive, because that has actually been demonstrated to be counterproductive in getting people to overcome vaccine hesitancy. So one example of this would be the rumor about the 5G Bill Gates tracking microchip being in the Pfizer vaccine. You can see a tweet from Ryan Reynolds when he got his vaccine, sort of tongue-in-cheek making fun of this rumor. But there is actually sort of a background to this that gives it a little bit of scientific and technical credence, just a little bit. But in 2019, there was a paper published by a group that was working with the Gates Foundation or funded by the Gates Foundation, who injected basically little tiny quantum dot technological devices in the skin of subjects that allowed for like infrared or near scanning data upload, essentially. So in this case, it was being used as a personal vaccine record, so that in places where people may not have vaccine cards, or it's harder to know if individuals have been vaccinated, a quick scan from a cell phone to these near infrared devices could show, oh yes, this person has had all their vaccines. So this technology exists. However, it does not track your movements. It is not hooked into a GPS. And most importantly, and this is the key fact you could offer your families, it's not contained in any of the COVID vaccines. So, ways to say, yes, okay, I see where you're coming from, but here's why this is not true and not something you should be concerned about in this setting is important. Similarly, answering any questions about anything that may have been left unresolved or unanswered is a great way to establish that trusted communication with your families. The last thing to consider is it really hesitancy, or is there a barrier to vaccination? So in many cases, a family may say, oh, I don't want to get vaccinated today. Thank you. I'll wait. But in that setting, is it because the only way they could get vaccinated that day is if they drove 50 miles to a max vaccination site in, Gaithersburg or something like that, and the family doesn't have a car and doesn't have means to get there? Or is it really just, if they had that, it had something they could take by metro today or a different way, they would get it today. So inquiring a little bit more about why they don't want it at that moment is also helpful and can stimulate those conversations and get at the real core of the issue. So wrapping up my talk, here are just two examples of a new ad campaign that takes a positive approach to addressing vaccine hesitancy, essentially involving families, saying it's up to everyone to help bring back the good things in life, and that everyone will benefit from vaccination for you and everyone in your community. And there's actually also a great website called COVID Latino that uses very fun animated positive cartoons to address some of the misinformation pieces, as well as vaccine hesitancy questions, both in Spanish and in English. But I advise you to check it out and share it with some of your Spanish-speaking patients because it's actually quite fun. And with that, I will leave you with, there are tons and tons and tons of resources out there addressing, giving information about the safety of these vaccines and also ways to address hesitancy and increase vaccine uptake. The next speaker will talk more about provider education modules, specifically targeting, outpatient pediatricians and providing them with some more tools and training about this topic. The CDC, as well as the IDSA, both have very robust websites with really every micro niche area that you could consider as a barrier. So addressing vaccine hesitancy in different cultural subpopulations, it's impressive. So I have included the links for these websites on there to check it out. And then several of the papers that I referenced in this talk, in particular the Rutan et al. Evidence-based strategies for clinical organizations to address COVID-19 vaccine hesitancy, which should be available online through your library or medical database. So thank you very much for this talk, and I welcome any future questions, and best of luck.
Trying to get to the right slide. So again, thank you very much to Dr. Bugard and Dr. Yance for setting up this opportunity. I'm Pavan Zaveri. I'm one of the medical director for our SIM program, as well as one of the pediatric ER doctors. But here talking to you about a series of 3 modules, COVID-19 vaccine education for pediatricians, that has actually been the wonderful collaboration of 5 sites across the country who are working together to put together a regional pediatric pandemic network, or previously called a National Pediatric Pandemic Coordinating Center. And so these 3 modules, sorry, mouse is going a little faster than I expected. What we've put together is 3 modules that include information about some of the basics of the COVID-19 vaccines, as well as a second module promoting vaccine acceptance with some simulated parent interactions where we're going to be providing feedback to you. And to ensure that we show that we demonstrate why we're doing this, there's a pre-test and a post-test. And all of this will only take about 1 hour. And it comes with CME or CNE for the nurse practitioners out there that provide primary care, as well as ABP Part 2 MOC. That QR code you can see, I'll show at the end as well, or this is the link for the website, but I would have to give you instructions. So just to kind of walk you through what these 3 modules have, the first one, again, as I said, was the basics of COVID-19 vaccines, set together here to give you general information about the COVID-19 vaccines, how they came about. And then module 2, addressing a lot of the points Dr. Jans mentioned about addressing vaccine acceptance, starts out with some basic information, some key concepts, including discussion about motivational interviewing, that strong provider recommendation, how to deal with the myths about the COVID-19 vaccine, and then provides an opportunity where 2 parents provide their questions, and whether video, audio, or text, you provide a response. And within a week or so, we'll be sending you feedback on how well that interaction went and where you could have identified some improvements. We close out that 3rd module with a brief Q&A with Nathan Chomilo from Minnesota on vaccine, the COVID-19 vaccine and equity. The 3rd module actually covers COVID-19 vaccine logistics in terms of how you need to set up things, were you to do it in your own pediatric practice, your own clinic practice, including a final lesson on setting up and simulating a COVID-19 vaccine clinic, where we give you a quick PDF document that walks you through how to deliver and conduct a simulation such that you're able to work out all the kinks in advance of running your COVID-19 vaccine clinic. Before and after this, as you can see, there's a pre-test and a post-test to demonstrate how it works, with simple questions about the feedback on the modules and some basic demographics and information about the content delivered. So this is the website, but if you would, many of you may have already received an invitation for this from Ellie Hamburger, who's been a great partner in this process. If you have any further questions and you have not received that, you can send an email to contact@nppcc.org, and one of several of us will respond to you with specific instructions on how to log in and complete these modules. And we'll take questions at the end.
Great. Thanks so much, Pavan. Good afternoon, everybody. I'm Kara Biddle here at Children's National. I'm a general pediatrician and have had the great opportunity to work on our outpatient vaccination program. So I'm going to provide you some updates. Next slide. It's been a really big week, hasn't it? So FDA news followed quickly by the CDC's recommendation for COVID vaccination for everyone ages 12 to 15 who don't have a contraindication. Next slide. So we knew it was going to be a big ramp up for this week. Currently here at Children's National, we're offering COVID vaccine to residents of the District of Columbia and Prince George's County, Maryland. As many of you know, we've had ongoing vaccination opportunities for 16 to 22-year-olds, and we're launching vaccination for 12 to 15-year-olds as of today, which is really very exciting. We're providing Pfizer vaccine, and just to give you a sense of the way that we've tried to ensure access to vaccine, we've provided the COVID vaccine at a number of locations around the district and in Prince George's County. So we had large events at the ARC in Ward 8 here in DC. We have ongoing vaccine administration at United Medical Center 2 days a week in Ward 8. We have vaccine administration here at the main hospital on Michigan Avenue several days per week. Looking forward to a big event at our new Research and Innovation campus next Saturday. And then finally, we've had some big events as well as ongoing administration at the Prince George's County Regional Outpatient Center. Many of you have also reached out to ask about your patients who live in other counties in Maryland and in Virginia. Unfortunately, we continue to need to limit to residents of DC and Prince George's County. And the reason for that is those are the jurisdictions that have provided vaccine for us to provide to our patients. And it's the departments of health in those jurisdictions specifically that have made the requirements that we need to offer it only to their residents. So for now, we're continuing to recommend that you direct your patients who live in other jurisdictions to the county and state websites. And hopefully all of us as general pediatricians will start to have the opportunity to have it in our practices in the near future. Next slide, please. Thanks to those of you who have used some of our referral opportunities up until now. From the very beginning, we've had a provider referral line, so you could identify patients that you felt to be at high risk. We've had a sign up on the DC Health vaccine portal, and we've also had a separate sign up for patients in Prince George's County. I wanted to share with you that we've consolidated all of those into one single sign-up link, which is available now on the childrensnational.org website, both in English and Spanish. It has been available for the past several days for folks to sign up if they were ages 16 to 22 and to pre-register for 12 to 15. Now going forward, we'll be taking sign-ups for DC and Prince George's County residents. I will share that the demand has been high, which is wonderful. It's wonderful to see how many folks are interested in getting their kids vaccinated, but you may experience times when it needs to be temporarily unavailable, and we'll get it opened up as soon as we can so that you can get your patients signed up and they can sign themselves up. The link there goes directly to the registration link. So you can either share or go to our website, or you could bookmark that web address there and go straight there. For you all to know, equity has been a really important part of our strategy. So when we do receive folks, for example, pre-registering for vaccine in that 12 to 15 age group, we are prioritizing folks who have chronic conditions, children and adolescents who are experiencing homelessness. We have some essential workers in that category. And we also continue to prioritize patients living in communities that have been most heavily impacted by COVID-19. So particularly here in the district, wards 7 and 8, as well as several other zip codes that have been identified as priority zip codes in the district. So that has been an important part of our strategy in distribution, and we will continue to use those guiding principles going forward. Next slide. And then just a moment on the news from yesterday that continued to roll in. Most of you have likely seen this already, but the AAP published a policy statement yesterday in which they formally recommend COVID vaccination for all children and adolescents 12 and older who don't have a contraindication. They recommend any COVID-19 vaccine that's been authorized by emergency use authorization for that age group. Next slide. And most importantly, they begin to give guidance about something we've all started to struggle with as we try to invite patients back into our practice and get them caught up on immunizations. Up until now, the guidance from the CDC, as you know, has been to avoid giving other routine vaccinations for 14 days before and 14 days after the COVID vaccine. I know in our practice, this has started to become an issue, and I've heard that from several of you as well. So importantly, the AAP policy statement says, given the importance of routine vaccination and the need for rapid uptake of the COVID vaccine, the AAP is supporting co-administration of routine childhood immunizations with the COVID vaccine, either on the same day or in that 14-day window before and after COVID vaccination. Next slide. Of course, we're also looking to the CDC. They have not formally updated their guidance in terms of on their website, but Dr. Wiederman shared with us earlier today that the Advisory Committee on Immunization Practices, or ACIP, met yesterday, and one of the things on their meeting agenda was a discussion of vaccine co-administration. And so part of that discussion included the fact that substantial data has now been collected about the safety of COVID vaccines approved under EUA. There's no longer such a compelling need to be understanding primary vaccine reactions. And we know from previous experience with other vaccines that the immunogenicity and adverse event profile of vaccines in general is similar when vaccines are administered alone or co-administered. And so ACIP as well is proposing to eliminate timing restrictions for administration of COVID-19 and other vaccines, which I just think is a really positive development so that we can, as we engage teenagers to come back into our practices, we can meet all of those needs at one time. Now, know that there's not a formal policy change yet from the CDC. I know we'll be looking for that as well as from our local jurisdictions. So I expect more to come over the next few days. Thanks very much. And handing it over to Dr. Rush.
Hi, everyone. Thanks so much. So I'm Dr. Rush. I'm one of the pediatric hospitalists, and I will briefly talk about our inpatient COVID-19 vaccination strategy and availability. Okay. So who can get an inpatient COVID-19 vaccine? So as of today, all inpatients who are admitted and are 12 and older are eligible for a vaccine. There's no residency requirement for patients admitted to the hospital. And vaccines are available to all of our patients 7 days a week. We, similar to the outpatient clinics, have Pfizer vaccines. We do ask that families are willing to return to one of our clinics for their second dose. So when discussing with families about this, definitely something to bring up. As you all are aware, patients admitted to the hospital may have complicated acute medical issues. So that being said, febrile illness is a precaution, but not a contraindication to the COVID vaccine. So we have made a couple of exceptions to eligibility. So patients who are under PUI precautions are actively being ruled out for COVID-19, have had their vaccines are deferred until they're off of precautions. If the patient has COVID and is admitted to the hospital, we are deferring their vaccine until an outpatient setting. And then our infectious disease colleagues have been very gracious in sharing their expertise with us about certain specific situations. If you have a patient that you're not sure would be medically ready for the vaccine, they have been able to help us with that. So a little bit of the logistics. So if your patient and family is ready for a vaccine and they are admitted to an inpatient unit, we're asking all of the primary medical teams to discuss with the patients and families. Nurses do screen all of the families on admission for eligibility and interest, but teams are directly talking to their families, providing the EUA and side effect informations, and then completing a paper screening tool and consent form. We know that some patients who are admitted to the hospital may not have a caregiver at their bedside at all times. So just highlighting here that telephone consent, unfortunately, is not accepted for inpatient vaccination, but a physical signature would be required. There's a vaccination plan that can be ordered ideally by 12 p.m. To be administered the same day in the afternoon. And then we have an inpatient vaccination team that is helping to kind of manage this and to answer any questions that we appreciate being alerted if you have an inpatient who would like the vaccine that day. And that's it. The vaccine will be then delivered to the patient's bedside, and the nurse will administer the vaccine, and then second doses are scheduled via our usual outpatient scheduling processes with our case managers and our schedulers. So just a quick note. So we've had a lot of families who are admitted that maybe they aren't sure if they're ready for the vaccine. So just wanted to encourage everybody to really routinely discuss COVID vaccination with all of your admitted patients very early on in the admission. So that that helps because there can be kind of multiple discussions as things move forward, and families may change their mind or get all the information that they need. We do have a kind of pre-populated Cerner documentation phrase that's equal COVID vaccination, in case you are an inpatient provider and you'd like to document your conversation so that we can kind of communicate across the inpatient team what has been discussed. As you know, we discussed a little bit earlier, providers are a trusted source of information for patients and families, and the inpatient admission in particular is a unique opportunity because it allows for multiple interactions over a little bit longer period of time than an outpatient visit. So we're just encouraging everybody to make the most of that opportunity that we have. We've had a couple of families who have been wanting to talk to their primary doctor or somebody who has an established relationship with them instead of potentially the inpatient team. So we've just been encouraging, if you are in the inpatient side, to facilitate these conversations as much as possible. And then just reiterating that we're recommending everybody discuss early and often with their families who are admitted. And then I just put our email there, which is inpatientvaccinations@childrensnational.org, in case there are questions that arise. That's it. Thank you.
Hello, everyone. I hope everybody is doing well. I'm going to dive right in to give you as much update as I can about the research study that will be starting soon here. And I put this very involved long title from the vaccine study that I will try to break down with you to help you understand what exactly is being planned. Assuming the slide will advance. There we go. Unfortunately, the best I can tell you now is that it will be starting soon. Depending on which hour I'm in, I hear different updates for things, but this is the Pfizer BioNTech mRNA vaccine that you're all familiar with. And here at Children's National, I'm involved, and my colleague, Alex, who you've just met, is the co-investigator at our site. And almost literally, there is a cast of thousands involved with this. But to break down the issues with this, it is a placebo-controlled study, and it is observer blinded, meaning the families nor the investigators know whether the child has received placebo or vaccine. And the endpoints are a bit different from the other studies that have preceded this. It's looking at safety, tolerability, and immunogenicity, but not efficacy, because these are relatively small numbers. We hope that COVID cases in general are going down so that there won't be as much exposure of the trial participants to COVID. So it's unlikely, excuse me, we'll have enough patients enrolled to actually assess efficacy. That's not the intent of this study. The study for the participants involves multiple visits. They have to keep an e-diary of symptoms after injections. There's some blood and nasal swab sampling involved at different times. But about 6 months after entry to the study will be unblinded, and those participants who receive placebo initially will be offered the vaccine itself, and we hope they will take that and continue in the study, and will continue in general about a 2-year follow-up, although the intensity of the visits and things are much less after the first several weeks enrolling in the study. Also, we hope to target those children who are most disadvantaged by COVID-19. So that means things like children of color, or for example, wards 7 and 8 in DC that have been hit hard by this. We're having evening hours that we hope makes it more accessible to working parents. They will be compensated, I think, very appropriately for the time they have to spend in the visits and transportation and just keeping up with the diaries and things. Whoops, sorry. So what's going on currently that you've heard about? There are very small numbers of participants, only at 4 centers in the US, not here. And there are 3 different age groups. And these are called dose ranging studies, trying to figure out what's the best dose of the vaccine to use in these different age groups, because clearly, it wouldn't be surprising if some of the younger kids don't require as high as the teenager and adult doses. So the dose we hope will be set, at least for the 2 oldest groups, by the end of this month, which could mean we start the trial in early June. And that main study, the so-called phase 2/3 trial, is at a ton of sites in the US, 3 other countries. The randomization, there will be 2/3 of the kids get vaccine, 1/3 placebo initially. And these are the numbers total. There is a competitive enrollment. So what that means is all the centers, many centers in the US, for example, we're all competing with each other until these numbers are reached. And when that is reached, some of the patients, some of the participants we have enrolled will unfortunately be contacted and told that we're sorry, we've reached our quota, we can't enroll anymore. And this could happen very quickly, just over a few weeks once each of these age groups is opened up. As I said, the timeline is a bit up in the air, but we are really depending on all of you because your patients may turn to you for advice on the study, whether it's something that is worthwhile or safe or things like that. And we will be getting information to you. There will be a registry that will open up on our website. We're just waiting for some regulatory things to happen. But once that's open, we will circulate the link widely, including to all of you. And parents can choose to just go on that site and enter some information about their children. It doesn't obligate them to anything. But we will look at the information and then start contacting parents of children who may be eligible to give them some more information and see if they want to proceed. So I'm hoping any minute now we'll have this registry open. And as I say, we will circulate that information widely. And with that, I will pass it on and wait for questions.
Great, thank you, Dr. Reederman. We actually might just go into some questions really quick before we summarize what we learned today. Dr. Yance has been answering some on the back end. So there was questions, is there a contraindication in children with seizures? And the answer is no contraindication there. Were they testing all patients post-vaccine in the new study, studying 12 to 15-year-olds? Or is the 100% efficacy based on no patient in the intervention group becoming symptomatic? And Dr. Jan says it was 100% efficacy based on symptomatic COVID. There may be more data regarding asymptomatic cases, but that was not the primary endpoint. First, back to her slides. There was a question about the co-administration of regular vaccines and the coronavirus vaccines in the kids 12 and up. And there, as we discussed, the CDC and AAP both recommend giving it at the same time, whether it's live or inactive. So there's no distinction made between those. If the child had a febrile or respiratory illness with negative COVID testing in the last 2 weeks, the question was, will that cause more adverse side effects? And it's hard to say, there's no subset analysis on that. So in general, though, the side effect profile should be the same. There were a couple questions on mothers who are breastfeeding, and I was trying to manage the chat while we were doing this, but Dr. Wiederman and Dr. Jans, I had found an article saying that there is evidence now that breastfeeding mothers do secrete some antibodies for their children. Do you have any further points you want to make on that, Dr. Wiederman or Dr. Jans?
Yeah, so there have been some studies coming out of the bigger maternal, pregnant vaccination of pregnant women that research has been done on that have shown antibodies in breast milk, even IgA in particular. But I think a lot of the questions in the chat were directed towards clinical testing for babies born to mothers who had been vaccinated. And at this time, there's no clinical recommendations on doing that. This is a discussion for another day, but they will, some protection, passive protection will be passed on via those antibodies. But, as the child ages, you still want to consider vaccination for, developing their own immunity, because those antibodies will eventually, wear off and be degraded.
Great, thank you.
And I would just add, I would caution practitioners against sending antibody testing on these infants because the commercial antibody tests that you can get are by no means answer the question about protection. This is a much more complex immune situation.
Yes, great. There are a couple other questions regarding eligibility to the vaccine. And Dr. Wiederman and Dr. Jans, I don't know if you guys want to just speak to some of these. They were talking about, is it okay to use NSAIDs to manage side effects versus Tylenol? That's a common thing that pops up in the media and news. And then things like having used antibiotics, getting sick beforehand, being immunocompromised. Would you like to touch on that?
Yeah, so regarding receiving the vaccine from a clinical standpoint, not talking about study or control conditions, but from a clinical standpoint, the only contraindication to receiving any of these vaccines is a known severe, so meaning anaphylactic allergy to some of the vaccine products, in particular for the mRNA vaccines, polyethylene glycol or similar materials. That is the only firm contraindication, absolute contraindication that has been released by the CDC or the vaccine manufacturer or the FDA. Use of antipyretics after vaccination is, is okay. There's no reason not to give them.
Great.
What else was there? Sorry.
No, I think that touches a little bit. We're getting a lot of questions coming. I'm trying to kind of put them together. There's a lot of questions related to the logistics of the vaccine. And I think given the audience, these are all very appropriate questions. So things about how avoiding waste, how to get the vaccine to their clinics, and some points on discussion. What I can say is we are going to be working closely at Children's to try to first get it into the Goldberg centers here associated with us, and then partnering with CNPA. And for any other partners out there, we certainly are going to work closely with the Pediatric Health Network to just figure out what information we can share and give you guys to make this an easy transition process to give you guys our best lessons learned. Dr. Wiederman, there was a question about inclusion and exclusion criteria for the vaccine trial. And like, can people live anywhere? Do they have to live in the city? Can they be in different jurisdictions? Are they allowed to have a prior COVID infection, other medical problems?
Well, let me just say the inclusion exclusion criteria are pretty complicated, and that's why we're asking families to do this initial registry screening. For the most part, for this current trial, we would like to enroll healthy children. We can't enroll anyone who's on any kind of medication that would alter immune responses, because that's one of the things we're measuring. So if somebody's receiving steroids, systemic steroids for asthma or things like that, they would not be eligible. In general, prior infection would not be eligible. But I will say there may be studies following this, including in some of those individuals. And we will go back to this registry if future trials come up and we find that some of our other children who have signed in are eligible. And it's, they have to live close enough to be able to come to the main campus for these visits, but we're not bound by the same geographic restrictions as with, regular EUA vaccine.
Great, thank you. We'll try to get to as many questions as we can. You guys are rolling them in, which is great. Someone asked, Stephanie Korn asked, are we waiting to get a final recommendation regarding giving the vaccine in the 2 weeks prior and after? And Dr. Wiederman, correct me if I'm wrong, but it sounds like currently the guidance is it's okay to do so if the patient is in need and you're worried that they wouldn't be able to come back outside of the 14-day period to get the routine immunization that they need.
Well, that was the feeling, of course, of the AAP and the ACIP. The CDC, as of a couple hours ago, hadn't changed their website yet for that. I suspect they will. I haven't had a chance to check it recently, but I would stay tuned today and tomorrow. We're going to get some clearer guidance, official guidance from CDC.
Great, thank you. Dr. Jans, this might be a good question for you. Richard says, I'm finding a lot of patients are hesitant based on the label's emergency use and still perceiving the vaccine as experimental. Besides just rehashing the safety numbers of the trial, any compelling counterpoints to this?
That is a challenge, and I would say, assessing their familiarity with the vaccine development process in general may be helpful. So knowing, even though this is faster development than normal, the processes are they're not cutting anything out. I'm trying to think, there are some good websites that have good illustrations of this information, and I can send that out to the group after the chat, just to kind of help talk people through it, infographics, but really pointing out that the relationship and the assessment of the data is happening on a rolling basis rather than in a stepwise approach. but they're not cutting any corners in terms of developing that. So that's a long way to say there are I think ways to address that, but I appreciate that that's a challenge. The word emergency is very scary.
Exactly. There was a question about waiting, recommending kids who recently had COVID to wait a certain amount of time before receiving the vaccine. I don't know if Dr. Yance want to answer that as well.
Yeah, so there is no longer any hard cutoff in terms of when children can be vaccinated. The only thing that really is advised is that they be recovered from their acute COVID. So no longer febrile, no longer having severe symptoms, and outside of their quarantine period in terms of meeting those guidelines. But I know previously there were recommendations about waiting 3 months, and that's no longer a part of the general guidance.
Great. I don't know if you guys know much about the perimyocarditis after the Pfizer vaccine, and if you want to speak to that.
Yeah, sorry, and I just answered that in the chat, but yeah, so there have been, I will say, internally, we have actually seen 2 cases of perimyocarditis in some of our teenagers that have had the Pfizer vaccine. And this is a phenomenon that is observed in other vaccines. So most notoriously the smallpox vaccine, but also influenza and various other vaccinations throughout time in different populations. So we don't know the exact mechanism, but the timing corresponds very well with the peak immune response. So we think it is immune mediated. It's usually transient. Both of these kids were actually minimally symptomatic and resolved without any intervention. So it is something that will continue to be monitored. If you look into VAERS, you can see, I think it's like 0.1% or less of all vaccines have reported cases of perimyocarditis with that. So that's going to be something that they'll continue to watch in their long-term surveillance. But it's certainly not vaccine unique for the COVID vaccines.
Great. Thank you, Dr. Janssen. Thank you to all our speakers today. Given the time, I think we're going to just stop the questions now, but I appreciate all the interest. I know this is an exciting time. And just to reiterate for everyone today, we are offering the Pfizer vaccine to all kids 12 to 22 who live in Washington, D.C. and Prince George's County, Maryland. We encourage you guys all to talk about vaccines at each interaction with patients and families. Just remembering empathy, listening, education, patience, and a strong recommendation go a long way. We have the educational modules, which will be sent out if you haven't seen them already. The ambulatory patients are being contacted proactively, but we certainly recommend you guys refer your patients to us if we can help. And we'll continue to vaccinate our children who are inpatient. We'll keep you posted on the Pfizer phase 3 trial that will hopefully start soon. And this is a new unprecedented time. We're all learning and growing. So we want to share our best practices with you guys. But if there's anything any feedback you want to give us or ideas, please don't hesitate to contact me. My final comment is just that we are teeing up to have some mass vaccine events likely over the summer just to keep meeting the demand of the community. And so if you are willing and able, it is very fun to engage in these vaccine events and to volunteer time. It is volunteer, but it's really pretty overwhelming emotionally sometime, like this morning, to watch these kids get the chance to re-engage safely with their communities. So I thank you for all that you guys do and wish you well and keep us posted on how we can be helpful. All right, take care, everybody.